is a casualty lying down on the ground. Literally had a metal pole fall from the top of the scaffold through the chest. Okay? So as has happened in the past, worst case scenario, you see that George is there, metal pole through his chest. First aider hopefully is going to come and render some assistance to this casualty at some point soon.
Not breathing, to be honest. Get us some help.
Then you go, call 999.
Oh, mate, please.
So as you have seen, trauma ready kits ready for any assistance needed. So as you can see there, George's got a large hole in the centre of his chest.
Mate, I'm not.
Mikey's going to very quickly cut his t-shirt off really fast. Got a big hole in his chest.
The ambulance is on its way.
Ambulance is on its way.
Mate, I'm going to die.
You see George's rest rate going really high. Got a big hole in the middle of his chest. Breathing really fast. Dead simple, blue Russell chest seal. Taken out the trauma ready kit. Opened up. Pulls off either side, nice and quick. Puts it over the hole in his chest. Stopping air going into that pleural space. Stopping that build-up of pressure, causing the lung not to expand and contract. So nice early essential care happening while professional care is on its way. Somebody's running 999. If this was a normal 999 call, they'll triage the call as quickly as possible. They'll work out that the patient's got penetrating chest trauma. Any patient with penetrating chest trauma will signify a quick response for any ambulance. In the UK, an ambulance would have to be here within 18 minutes. It seems like a long time. What they'll also send is a critical care team to any penetrating chest trauma because of what he jumped up and being replaced with a mannequin. Exactly the same way. Level 8 team arrives. And what they have in level 8 teams is normally a critical care doctor and a critical care paramedic, which we have. So then, what they can see is a unconscious patient lying on their back in the middle of the warehouse with a large open chest injury. The kit that they would have to get is their normal response kit, blood, monitor.
Hello, boss. Here we go. Hello. My name's I'm one of the doctors.
So you've got a patient very quiet, lying on the ground, breathing very quickly. You're going to do a quick assessment of the casualty, put on some monitoring, make sure there's no other catastrophic wounds or any life-threatening injuries that the patient may have sustained through the incident. So they've found that he's got a single penetrating wound to the chest. The patient's rest rate is getting quicker. And you can see he's very pale. Breathing rate is very shallow. And working out that the patient is really struggling to breathe.
Can you hear us?
No response to any verbal stimuli, no response to any painful stimuli. I'm going to insert an eye gel in the patient's mouth, ensuring that they've got an intact airway. Ventilating the patient now to assist the respirations, making sure that they're as good as it can be. The patient's rest rate is dropping quicker and quicker. You can see on the monitor that they've got a tachycardic patient, so his heart is beating very fast. Ollie's taking a carotid pulse and a femoral pulse, and it's coming back at about 180 beats per minute. Very, very weak. So the casualty is moving from into what we call a low flow state, where the patient has not got the blood pressure that they need to circulate that blood volume around the body. That is keeping the brain perfused, it's keeping the heart perfused, that's keeping all the vital organs working. So the patient is moving forward into what we call traumatic cardiac arrest. Now in traumatic cardiac arrest, what you're not going to do, potentially is not going to do, is chest compressions. Because the heart is slowing, but what's actually killing the patient is what's going on inside the chest. It's not an electrical problem. So they're not going to do chest compressions and try and shock the patient. What they're going to do is kind of reverse the cause of the cardiac arrest. So the patient's now in a low flow state. So they've got very little movement of the heart. So as they've got very little movement of the heart, they might consider giving blood products to the patient, or they might consider doing thoracostomies, which we talked about earlier, where you put a hole in the chest and see if that's the tension in the thorax that's killing the patient, or any other causes of reversible traumatic arrest, such as blood loss, etc. So you failed on an intravenous access.
How's that? So just remind me, current odds?
Current odds are heart rate 180, rest rate, being ventilated.
Lovely. Any pulse?
Carotid pulse, you cannot feel a carotid pulse.
Okay, so we have a low flow state.
You have a low flow state.
So can we progress to thoracostomies?
The critical care team now going to do thoracostomy, so they'll do these bilaterally, so on both sides of the chest, to expel any air that's squeezing those lungs and not letting them ventilate as quickly as normally as they should. So even though this is a pre-hospital setting, we'll try and do everything as sterile as possible. Clean with betadine or iodine solution. Using a scalpel, they'll make an incision into the sides of the chest. What they may get is a hiss of air or a large amount of blood coming out of those thoracostomies. Unfortunately, with this patient, they don't get either. So what they're going to do is open up those holes in the chest, making sure that they're in the pleural cavity, so exactly the same way as we do with the needle decompression that you did earlier. So Ollie's finger just went all the way in there, Sarah's finger's going into the right side of the chest, sweeping around, making sure there's no blood or air coming out of there. There wasn't. Still in a low flow state, no return of spontaneous circulation.
So we progress to thoracotomy.
They're going to go forward to a thoracotomy. They're going to open this patient's chest. So scalpel makes the first incision across from right to left, cutting through the subcutaneous tissues, the fatty tissues. Then using tough cuts, cutting along the intercostal muscles in between the ribs. Then we see how good their aim is and see if they follow the same track. And it matches up, which they do. They get to the sternum. What they're going to do is snip through the sternum of the patient's chest. Through the sternum, and they're going to pull the chest open.
Can I ask you to hold that for me?
Once you pull the chest open, you've then got exposure to the lungs, to the heart. You can work out what the cause of the cardiac arrest is. So is it a lung problem or is it a heart problem? What they can see inside the chest is two quite dry lungs. What they can also see is a heart which has got blood around it. So the heart sits inside a sac called the pericardium. And just like the pressure around the lungs, if you've got a build-up of blood around the heart, that's not going to allow the heart to effectively pump. So what Ollie's doing there is cutting the pericardium. Then get rid of the blood that's around the heart. You then deliver the heart. check both the back and the front of the heart, and you'll find a wound. It's a hole in the heart which you will close. Now there's a different number of methods to closing a hole in the heart. What they're going to do is staple. So Sarah's just using normal staples or surgical staples, not normal ones from Staples or B&Q or Smith. They're using surgical staples, which are very similar, just to close the heart, close the hole in the heart. And what they'll then do is internal chest compressions. So just like you do for CPR externally, what they're doing is internal chest compressions, squeezing the heart from the apex of the heart upwards, pushing that blood around the body, hopefully getting a return of spontaneous circulation. So we'll be looking at the monitor, seeing if there's any changes, seeing if the end tidal, so the amount of CO2 that's being blown off the patient raises or changes, which is normally the first sign of a potential return of spontaneous circulation. And Ollie will just be doing chest compressions just as you would do with external chest compressions, but we're obviously inside the patient's chest at this point. Ventilation-wise is going on. And now that they've done that, what they can consider doing is giving the patient blood. So most, if not all, level 8 teams throughout the UK now carry blood products. So it's made up of plasma and whole blood. Plasma and red blood cells. So they'll carry different numbers of units and different units of components. They'll administer those components in a certain method to ensure that they're trying to aid clotting and also aid oxygen maneuvering around the body. So we've got IO access in place using Neo in the humeral head. I think. Can't see it. Yeah, okay.
We do.
Thank you. And now that we've got access to the patient's heart, we can circulate that blood that's being pumped around the body, circulate that blood that's being given to the body through the IO by doing those chest compressions, circulating that blood and keeping an eye on the patient to see if they have any return of spontaneous circulation. So it's the last chance saloon of these patients is to do a thoracotomy. It's a normal commonplace in the UK now. It's a normal thing that happens in all level 8 teams. Unfortunately, it's become so much commonplace that it's one of the most, well, it's one of the most common procedures that level 8 teams do. I'm sure there's a bystander.
Thank you. You just hold that up. That'd be wonderful. Thank you very much.
What have we got then?
So you've got same as we are at the moment. So you've got the same heart rate is changing slightly. You can see a change of the end tidal. You can feel some movement of the heart in between your hands. You see some flickering of the heart in between your hands. Continue to support that, making sure there's enough blood flow throughout the body. So that patient has gone back into a low flow state, so they've progressed from being in a no flow state to a low flow state because we've dealt with that problem, which was a bleed in the heart around the pericardium, which they've evacuated. That heart is now flickering by itself. You can see a rhythm on the monitor. Feel a palpable pulse at the carotid, and the rate is approximately 140 beats per minute. End tidal is about 6.2.
Sarah, we've got a rock. Time noted. Plan for us to move on from now is we need to show that I wait through the system waking up. We're going to do a RSI, that's okay. So if I get through together, you get the OA together, and then we'll do a checklist before we start.
So what the team are going to do now is progress to an RSI. So they're going to give this patient a pre-hospital emergency anaesthetic. So that's giving drugs to keep the patient asleep, to keep them in a comatose state so they don't wake up. Remember, this patient just had a hole in the chest. They haven't had any drugs to keep them asleep. So there is a chance they could wake up. So we obviously don't want that to happen. We want to keep as nice and stable as possible. So they'll give drugs, normally rocuronium and ketamine, to keep them stable whilst they transfer the patient to hospital. So as you can see, Ollie's getting ready there to do a checklist. So obviously this is a high pressure scenario. Checklists are used in all level 8 teams across the country to keep things as safe and effective as possible. So just like the Rampart system or a colour coding system, we have checklists that make decisions as easy as possible to increase and reduce that bandwidth and that pressure in what is a very difficult situation.
Yeah, have you got one?
I've got as well.
Yeah.
Colin, oxygen.
Attached.
Vivian.
In situ.
Entitled.
Reading.
6.3.
Blood pressure.
Cycling.
Last blood pressure.
92/66.
Lovely. Pulse on.
On and stats are 88.
IV, IO access. So we've got one.
IO.
Suction.
You have
Then the card, check working. Laryngoscopy.
OUD out. Backfall blade.
Lovely. Continuity. Boom.
We don't have a
Video. And tube.
Size 8 and tested.
Bougie. Syringe.
Here. Attached.
Airway pouch.
Difficult airway patches by the patient's right shoulder.
Lovely. Lovely. It's going to be ketamine, it's going to be 30 for the kick. Muscle relaxant is going to be brochure at 60. Different airway break. On 8. Tube. On B. Hydro. On C. Wait, max. On neck. GMI 1. Excellent. Lovely. Any concerns about can't start?
No, should we just
So run through that checklist and made it as safe as possible. So they're giving the patient the drugs.
Time
So
on.
look,
13.5. What's going in?
drugs are going in now. They'll give the patient approximately 45 to 60 seconds for those drugs to circulate around the body to have an effect.
Good. I'll vote on that coming in.
And for the purpose of the scenario, we'll say that those drugs are very quickly circulate around the body and the patient is ready to be treated.
Okay. So, I do mind. That's ready. Okay, could you just pass me the bougie? Okay, going in, sweeping the tongue. Okay, so I have a grade 1 for you. Thank you very much. Oh. Sorry. Sorry, the bougie. Okay, that's through the course. Tube, please.
Loaded. The bougie.
I've got the tube. Gone in.
Tubes in through the cords.
Yep, bougie out. Thank you very much. Okay. Oh, oops, a daisy.
And you get rise and fall of the chest bilaterally.
And title.
End tidal is there, 5.8. Tube secure. And stop there.
Ladies and gentlemen, join me in the middle down, carry around the floor.